Oh, good afternoon, everyone. No, today we will discuss what we call our um, proper physical exam. We will start with our central vascular system. Okay? Now, when we say central vascular system, no, it refers to assessment of the heart. Okay? When we say peripheral vascular system, it refers to the assessment of the rest of the blood vessels, no, outside of the heart. No? So this is just a guide. This picture is just a guide. Later on, if I discuss something, we will use this guide. Okay? So the equipment we will use, number one is a stethoscope, a pen light or examination light, a watch with a second hand, a centimeter ruler or more commonly a tape measure, and a pulse oximeter. Okay? A pulse oximeter. So this is a stethoscope, no? We've already discussed this before, but I want to re-emphasize once again. This is our diaphragm. This one, this side. While this one is our bell. Okay? Our diaphragm is used for high frequency sounds. Okay? Mostly mga normal sounds. While our bell is used for low frequency sounds. Ayan. This is what we call a pulse oximeter. Now, I want you to notice, class, that there are two numbers when it comes to a pulse oximeter. Before we discuss those two numbers, let us define a pulse oximeter first. A pulse oximeter is a tool that is used to measure oxygen saturation, or what we call our blood oxygen level. Blood oxygen level. Okay? When we say oxygen saturation or blood oxygen level, this is the what we call amount or percentage of hemoglobin. If you remember from your anatomy, no? Hemoglobin is the element the compound that carries oxygen. Okay? Percentage of hemoglobin currently bound to oxygen. Okay? Basically put, no, this is the amount of this is the percentage of hemoglobin that has oxygen. Okay? Normally, when we're talking about pulse oximetry, it is 95 to 99%. Okay? This is what you will see here, SpO2. Okay? SpO2. Mo na siya. Mo na siya atong gitawag nga blood oxygen saturation or saturation of oxygen. Mo na siya 92. Kini siya, as you can see, it is less than 95. Okay, if it is less than 95, if it is less than 94, okay, 94 na lang, it is what we call, the patient might be suffering from what we call hypoxemia. Okay, when we say hypoxemia, there is decreased O2 in blood, di ba? Decreased O2 in blood. Now, as I've said, no, dahil duha ka number. Okay, the second number is your heart rate. Okay, heart rate or pulse rate. Same ra na silang duha, class. Do not ay paglibog-libogan, no? It's just the same. Di ba? Normally, the heart rate is 60 to 100 beats per minute. Okay? If it is more than 100 plus, that is tachycardia. Di ba? Tachycardia. If it is less than 60 or less, it is bradycardia. Di ba? Now, this variant, no, kini siya yung na variant of pulse oximeter. This is relatively cheap. Actually, you can buy this sa Shopee. Around mga 100, 200 na ara siya, no? Ang cost of materials mo na is not very expensive, but this is very rudimentary. It is also accurate as well, di ba? So, mo na siya accurate, po na siya. However, class, in the hospital, we commonly use is kinimay ani na type. Okay, these are more industrial grade. Ang tendency man good is this one, the blue one here, you can remove it. You can remove this part, and then you can attach it to a cardiac monitor. You can attach it to the cardiac monitor. Kini siya na part, this is the one that will go or attach to your finger. This is the one that will attach to your finger. It is the same thing, no? But this one is more modular, so to speak. Okay? Now, class, I want to re-emphasize once again our classification of pulse to net. No, as I've said last time, di ba? As I've said last time that only green or 3 plus is normal. However, after further reading, no, especially reading on the books used for the board exam, no, they have classified that number 2 is also normal. Okay, number 3 is also normal as well, but number 2 is weak normal. Okay, while number 3 is what we call our strong normal. Okay, strong normal. So both of these, no, are normal. Okay, both of these are normal. Ayan, that's the clarification na, no. Okay, so first, when it comes to our assessment, is we will assess our neck veins. Okay, our neck veins. Now, first we will assess the jugular vein. Now, being a vein, no, it carries down unoxygenated blood. Okay, the jugular veins are found at our neck. Now, what we do, class, is we position the patient in a supine. When we say supine, flat on bed position, with the head of the bed elevated 30 to 45 degrees. If you cannot elevate the head of the bed, no, let's say for example the bed is not what we call this modifiable, like in the hospital, you can actually tilt it. You can use a pillow. Okay, and then after that you ask the patient to turn their head to the left. Okay, so sir, look to the left, and then using a pen light or examination light, inspect the jugular veins. Okay, inspect the jugular veins. Now class, so muna siya, no, it looks like this. Ayan. Now class, normally like this, normally, okay, the jugular vein is not visible when upright. Okay, normally it is not visible when they are upright. However, it is visible if what we call this, the head is tilted. Okay, if the head is tilted, is visible. As you can see, no, there is, if you can see this one, there the pit, there the pit. Okay, there. No, it's like it's a very faint discoloration, but it is very obvious, no, na ay vein diha. There is a vein there. Okay, so muna siyang normal. When they tilt their head, that is when you can see it. Okay, that is when you can see it as a nurse. Okay. However, class, this is abnormal. Okay? Abnormal findings include what we call, class, our... Ay, wait, at listen, ganang klaro. Okay, abnormal findings include what we call, class, our distension or bulging of jugular vein. Okay? Distension of bulging of jugular vein. This is caused by... As you can see, oh, nagburot gyud siya, no? It is very much bulged, no? This is caused by what we call increased venous pressure. Okay? Most commonly seen, class, in right-sided heart failure and pulmonary embolism. Okay? Now, sir, what do you mean, sir, that it is caused by right-sided heart failure and embolism? Yan na siya. Let's go back to the picture, atong guide. Okay? Now, this is the right side, diba? This is the left. Normally, no? Let us start with right-sided heart failure. Normally, as I've said, no, the patho physiology for heart failure is that there is backflow. Diba? There is what? Backflow. Now let's say for instance that this blood here, okay? Kini siya. This blood here backflows, okay? It goes back to your jugular veins, okay? Let's say for example the blood is now here. Now, since there is a lot of blood here, there is increased venous pressure, correct? Venous pressure. Because as I've said, no, all the blood is flowing back to its original source because there is backflow. Okay? There is backflow. Okay? Yes, mga no? So there's backflow. And tendency is if all the blood is here, it will overwhelm the vein. If you remember the veins anatomy, no, it has very thin walls. Okay, it has very thin walls. So if there is increased pressure, that there is a tendency that it will bulge or enlarge. Diba? If there is too much blood, obviously it will enlarge. No? Okay. So that is for example, right-sided heart failure. There's backflow. Now, sir, what if it is pulmonary embolism? Very simple. It is the same principle. In pulmonary embolism class, let's say for example, the embolus, okay, or the thrombus is lodged here. Okay? Lodged here. So blood cannot easily pass through. Okay? Blood cannot easily pass through. It will have a difficulty passing through. Therefore, a lot of blood will stay here. Okay? A lot of blood will stay here. And because there is a lot of blood, obviously there is an increase in pressure. Okay? Because there is an increase in pressure in this side, there will be backflow. Okay? Going up to your superior vena cava and going down to your inferior vena cava. Once again, same principle applies. No, na backflow. There is backflow. There is backflow. Okay? There is too much blood here because it can no longer go up because of gravity. It can no longer go up because of gravity. And therefore, this will distend or enlarge. Same goes with the lower leg. Diba? If it goes down, it backflows to the lower leg. Okay? There will be what we call venous pooling. No? Venous pooling. Ayan. So, that is a simple, what do you call this? Spoiler, no? For your medical surgical nursing. Ayan. So, that is how you assess your jugular veins. That is how you inspect your jugular veins. Okay? Next is to assess your carotid artery. Now, class, since this is an artery, always remember, class, arteries have pulses. Okay? Arteries have pulses. Now, what do you mean by there's a pulse? Obviously, no. Since there's a pulse, we can palpate it. Now, class, here's the thing you have to take note. Okay? You have to palpate the carotid artery for pulse. Okay? Palpate for pulse. If the patient is middle-aged or older, okay, or if you suspect that they have a cardiovascular disease, then auscultate using the bell. Okay? Auscultate using the bell because at this point we are now assessing for bruise. Okay? We are now assessing for bruise. Now, class, when we say pulse, class, no, it should be the same as our heart rate. Okay? When you assess for when you palpate for pulse, it is the same as our heart rate. So, around 60 to 100. Yes, asabi to. Ayan. Okay. Generally, the carotid artery's pulse is around here. So, that is where you will palpate. Okay? And when you palpate the carotid, here's the thing you have to remember. Okay? The thing you have to remember when it comes to palpating the carotid artery is you have to palpate the carotid artery one at a time. Okay? Meaning, you start with the left carotid and then after that, you follow it with the right. Okay? The tendency, mga God, is if you palpate it both at the same time, you might occlude or impede blood flow going to the brain. Diba? Kaya because you are pressuring, no? You are pressing on the carotid arteries. You might impede the blood flow going to the vein. Ang tendency is the patient might feel dizzy. Okay? When palpating class, take note of pulse thrills, okay? Elasticity of the artery and amplitude, okay? When we say pulse thrills class mo ni siya nga mga, this is what we call our vibration. When you touch the pulse, no, and you feel every time that it beats, no, every time that it pulses, that there is a vibration, no, that is an abnormal finding. Okay? Now, when you are auscultating the carotid, ask the patient to hold their breath. Okay? The reason why we do it is to prevent hearing breath sounds. Okay? Ang tendency na is you will now hear, no, katong mga bronchial sounds if you what do we call this, ask if they breathe, no, so ask them to hold their breath. Okay, so yeah, mo na siya, no. So this is how you auscultate the carotid artery. Okay, ayan. As you can see, they are using the bell part, no, bell part. Okay, this is how you palpate it. Yan na siya ginaong class using two fingers specifically around the lower the anterior neck, no, or the side over the lateral neck, no. As I've said, no, it has to be one by one. Okay, so what are the normal findings for carotid assessment? Number one class is there should be no bruise. Okay, no bruise. Okay, no bruise. As I mentioned before, no, bruise kato na siyang swishing sound caused by turbulence, okay, or other sounds. Okay, there should be no bruise or other sounds. Okay, the pulses should be 2 plus. Okay, 2 plus pulses. When we say 2 plus class, it is weak normal. Okay, 2 plus. Okay, and it should be bilateral. But when we say bilateral, both arteries should have pulses. Okay, next is elastic arteries. That is also normal. When we say elastic artery, what we mean by that is if we move our fingers from side to side, no, when we palpate it and when we move the arteries from side to side, we can also move the arteries. Okay? Actually, you can test this right now with your hands. If you are relatively thin, no, kung niwang-niwang ka, in your dorsal part of your hand, makita, you can actually see the veins, no, in the arteries. You can try holding your veins and try moving it around. Actually, it is very elastic when it comes to that. Okay? And lastly, there should be no thrills. Okay? No thrills or no vibrations. Okay? No vibrations. Now, for our abnormal findings, no, we have to split it into two different parts, namely among which is for auscultation. Okay? Wait. Okay. Namely among which, no, is for what we call auscultation. Okay? Auscultation. Amo ni siya abnormal findings. Okay? Abnormal findings for auscultation include what we call our bruise. Okay? Bruise. Okay? Bruise are blowing or swishing sounds. Blowing or swishing sounds. These are caused by what we call turbulent blood flow due to narrowed vessels. Okay, due to narrowed vessels. Okay. Whereas class, no, that is the abnormal finding for auscultation. The abnormal finding naman for what we call this our palpation. Okay, as you can see in the picture, no, at a lineup. Okay, the abnormal findings for palpation are quite a lot. Okay, palpation. First is what we call our pulse inequality. Okay, when we say pulse inequality, no, what we're referring to is one side is stronger than the other. For example, ang left side, it is much stronger than the right. That is pulse inequality. Okay? Now, pulse inequality is caused by what we call occlusion. Okay? Occlusion gani, when we say occlusion, blocked. Okay? Or constriction of one carotid artery. Okay? Whether the right or the left. Okay? Next is what we call our weak pulses. Okay? Weak pulses. Ayan. Mostly, it is kana mga +1. Okay? Kana mga the pulses that are +1. Okay? Now, this is caused by what we call our hypovolemia. Okay? Hypovolemia, which is the term we use to describe decreased fluid volume. Okay? Or fluid volume deficit. Okay? Aside from that, it could also be caused by decreased cardiac output. Okay? Decreased cardiac output. Number 3 class is what we call our bounding pulses or very strong. Okay, bounding pulses. These are the pulses that are plus what? +4. Okay? This is also caused by the same hypovolemia due to decreased fluid or decreased fluid volume or this decreased cardiac output. Now, sir, tell me, how is it that when the pulse is slow and when the pulse is really strong, that it is caused by the same problem? Now, class, what I failed to mention, class, or what I have not told you yet, no, is bounding pulses occur early. Okay? Early. Sa'yo. Okay? Early. Early. Okay? Whereas decreased occurs late. The tendency of the heart is when there is a decrease in fluid volume or cardiac output, no? If there is a decrease in fluids in the body, your heart, no, will try to compensate by increasing the heart rate. Okay? Increasing heart rate. Now, when it increases the heart rate early on, no, it will cause our bounding pulses. Grabe, it will because of the increased heart rate, no. As I've said, no, it is a compensatory mechanism for hypovolemia so that fluid can actually move. It will cause bounding pulses, no. Pulses that are really strong. However, class, later in this problem, class, the heart will eventually tire. Okay? When we say tire, kapuyo na imong heart. Okay? Your heart will be tired and the heart rate, instead of being increased, will now decrease. Okay? Now, decrease. And because of that, it brings with it, no, weak pulses. You have to take into consideration, class, that when someone is dehydrated, okay? When someone is dehydrated, you have to check their heart rate. Okay? After you check their temperature, di ba? P. Di ba? Yung vital signs, TPRBP. First is temperature. After that, you check their heart rate, no? It is crucial that you know the difference, no? Because sometimes you might see it very fast, sometimes you might see it very slow. It just tells you what stage you are on. Okay? So when a patient comes in and their pulse rate, no, is very fast, okay? Check their pulses. If it is bounding, it means they are early in dehydration or they have early hypovolemia. Okay? Next is number 4, class, our thrills. Okay? Thrills, as I've said, class, these are vibrations during palpation. Okay? This is observed, class. This is due to a narrowed artery. Okay? Narrowed artery. Also known, class, when we say there is a narrowing of a blood vessel, we call that, class, stenosis. Okay? When there is a narrowing of the blood vessel, we call that stenosis. Okay? And number 5, no, is loss of elasticity. Okay, immovable. Tendency is your blood vessel will now be immovable during palpation. This is due to the hardening of the artery. Okay, specifically, when there is hardening of the artery, we call this class arteriosclerosis. Arteriosclerosis. Ayan. Do not confuse it, ha? Do not confuse it with atherosclerosis. Atherosclerosis is a different but similar, problem. In atherosclerosis, there is narrowing of the blood vessel, not because it has hardened, but because there is fat deposits. Okay, when we say hardening of the artery, it is arteriosclerosis. Okay, ayan. Next is we will inspect and palpate the apical pulse site. Now, we already know, class, where the apical pulse site is, as we've discussed before, to inspect and palpate, Sir, why do we inspect the apical pulse site? You will know later why. Okay? Now, class, with the client on the same position as prior, So, kato siya supine with the head of the bed elevated around 30 degrees. Stand on the client's right side and look at the apical pulse area. Okay? Apical pulse area. It is around, as we mentioned, at the 5th intercostal space in the left mid-clavicular line. So, kini siya 1, 2, 3, 4, 5. This is the 5th intercostal space. This is the mid-clavicular line. So, this is the area we are referring to. As you can see, it is directly on the tip of the apex. Diba? Apex, apical man. When we are palpating, use your finger pads. Specifically, sometimes clinicians will use 2 finger pads. Sometimes they will use 3. Okay? Magpili ra. Depende ra. It depends on your approach, what you really prefer. Okay? So, normally, class, Normally, the apical pulse is, ato here, is not here. Ato is, ayan. Normally, class, the apical pulse is what we call sometimes visible. Okay? When we say visible, class, bounding. What we mean by that is sometimes it will murag mupitik ang imong skin, but the skin will actually protrude a little bit. It will pulse, the skin will pulse, but that is very very uncommon, but it is still normal. Okay, the area is around, let's see, 1 to 2 centimeters in size. Okay, what we mean by area is around 1 to 2 centimeters is if you have marked correctly the site, mura na siya imong square. You have to imagine that there is an imaginary square. It should be no greater than 2 centimeter by 2 centimeter. Meaning, if you are auscultating outside of it, you should not be able, when you are palpating outside of it, you should not be able to feel it, diba? When you are palpating here, you should not be able to feel a pulse, diba? However, class, we also have a few abnormal findings, namely among which is number 1, class, pulsations. Okay? Pulsations outside. Okay? Outside of apical site. Pulsations outside of the apical site. Okay? Pulsations outside of the apical site, which is characterized by heaves or lifts. Okay? Heaves or lifts. When we say heaves or lifts, class, it means that the skin is heaving. Okay? When we say heaving, more siya of breathing, When we say lifts, it feels as if the skin is about to lift. Mura bitaw siya musaka na, no? So this is a sign, no? This is a sign that the ventricles are overworked. Overworking ventricles. Okay? Overworking ventricles, no? Next is a what we call displaced apical pulse, or larger than 2 cm size. Okay, this is caused by what we call cardiac enlargement. Okay, enlargement, also known as your hypertrophy. Okay, or cardiac hypertrophy. Now, ngano mo displaced? Why is it displaced, man, sir? Now, let's say for example, okay, your heart is enlarged to be this big. Kana. Ay, dako ra kayo. Binuang. Okay, let's say like that. That large, no? Obviously, no, if the apical site is normally where we would expect it to be around here, but if we still hear pulsations here or here, it means that our site is now bigger, diba? This is around, let's say for example 2 plus, okay, or let's say for example 3 cm, no? So ang tendency na is obviously we are hearing that because there is an enlargement of the heart, diba? We are hearing that because there is an enlargement of the heart. Same goes with the displaced, what we call this, apical pulse. Normally, we can hear the apical pulse here. But if we, for example, hear the apical pulse here, okay, around this part, it means that it has moved, diba? Nibalin siya. So, ang tendency there is, you can conclude, no, or we can, it is indicative of an enlargement of the heart, because it will only occur if there is an enlargement of the heart, diba? Ayan, wait. Next is what we call auscultation. Ayan, auscultation na tayo. Hold on. Kapit na. Kita mo man ang first part. Wait. School. Now, when I say auscultation, no, we will be assessing for what we call our rate and rhythm. When we talk about rate, class, what we are referring to is the speed of the pulses, no? So, normally the rate is around 60 to 100, diba? We already know this. Magbalik-balik na lang tayo, class. Normally, it is 60 to 100 beats per minute. Okay? Whereas, the rhythm, class, normally it should be regular. When we say regular, class, it should be like love-dub. Consistent, diba? Consistent, no? Consistent. Okay? Now, class, there are a few abnormal findings, namely among which is what we call number 1, our bradycardia. We already know what bradycardia is. Okay? Bradycardia is a heart rate that is less than 60 BPM. Okay? Less than 60 beats per minute. Okay? And we also have what we call our tachycardia. Okay? Which is a heart rate that is greater than 100 beats per minute. Okay? Both of them can be caused by a variety of factors. But one of the main causes when it comes to brady and tachycardia is, as we mentioned before, decreased cardiac output. Ayan, decreased cardiac output. Okay? Another cause is what we call our decreased fluid volume kato atong hypovolemia. And lastly, class, dili ka siya common, no, but still relevant, no, our hormonal imbalances. Hormonal imbalance. Okay? Two hormones specifically can control your heart rate, no? Your epinephrine and norepinephrine. Okay? Because both of these, no, can trigger what we call our sympathetic nervous system. So if there is an increase in epinephrine, it will increase the heart rate because it activates the sympathetic nervous system. It also goes the opposite direction. If there is a decrease in epinephrine or norepinephrine, it will also slow down your heart rate, diba? Because it activates your parasympathetic nervous system. Okay? So, muna siya, no? There's actually a lot of diseases, a few diseases that could affect based on your hormonal imbalance. One of the things I remember is what we call your pheochromocytoma. Okay? Pheochromocytoma, which is a tumor found at the top of your adrenal glands. Okay? When there is pheochromocytoma, there is an increase in the production of both epinephrine and norepinephrine. So, ang tendency is there is increased heart rates. Okay? When it comes to rhythm, class, the abnormal finding is very simple. Irregular rhythms. Okay? Irregular rhythms. Irregular rhythms. Such as what we call flutters, premature ventricular contractions. Okay, when we say PVCs, no, premature ventricular contractions, what we mean is that the heartbeat occurs faster than expected. Okay, now class, when there is premature ventricular, when there are irregular rhythms, class, okay, refer to MD immediately. Okay, refer to MD. Possible need for ECG. Okay? Because heart rhythms, no, especially when they are regular, no, they are very problematic. And tendency magod is the heart might shut down, no, or it might develop into a much worse form of rhythm. Okay? Next is, if irregular rhythm is present, assess pulse deficit. Okay? Pulse deficit. Palpate the radial pulse. If you remember, the radial pulse is the one at our thumb side, diba? At our wrist, no? While auscultating the apical pulse. So one hand should be at the wrist of the patient, while the other hand should be auscultating the apical pulse. Now, you count for 1 minute and then compare. Okay? Yung muna siya i-compare. So, yes. Ang mahitabo mo na siya. Normally, our radial pulse and apical pulse should be identical. Identical in both rate and rhythm. In rate and rhythm. Now, sir, what do you mean by identical? Okay? For example, class, the apical pulse is, let's say, for example, class, 97 beats per minute. Okay? If the radial pulse is, let's say, 95 beats per minute, that is close enough. Okay? That is identical. Doon na kayo na. Okay? However, class, if for example, the radial pulse is 60 and the apical pulse is 94, now that is too far. Okay? That is too far. No, layo na kayo na, no? So, muna siya, no? Abnormal findings include what we call a pulse deficit, wherein one pulse is much stronger or faster between the others. Okay, there is a difference in pulses. Difference in pulses, no? So, yeah, this may indicate a few indicative, no, this is indicative of a few irregular rhythms, okay? Rhythms, no? Most of these rhythms, no, will be discussed in your medical surgical nursing in cardio. Malingaw jud mo na class. You will have a fun time with MS. If you think that this subject is difficult, then be ready. Okay? If the time na if during the time where I was discussing no backflow, backflow to the carotid artery, if you found that very complicated, good luck. Okay, yan lang masasabi ko sa inyo. Okay, next is what we call our auscultate for heart sounds. Now, normally, we should use the diaphragm for normal sounds and use the bell to auscultate for extra heart sounds. Okay? No? So, we have to auscultate the whole precordium. When we say precordium, it is the entire area of the chest, this part. Okay? We should auscultate the entire area around the heart, no? So, normally, there should only be S1 and S2. Okay? No extra sounds. Dapat wala extra sounds like your S3, S4. Okay? It should be at your S3 and S4. Now, if you remember class, no, your S1 is your lub, diba? And your S2 is your dub. Okay? So, this is lub. Here siya is dub. Now, class, your S1 no is best heard at the apex, while your S2 is best heard at the base of the heart. Okay, has best heard at the base of the heart. Now, for abnormal findings naman, we have our S3, the presence no or positive S3 and S4. Okay. This is your ventricular gallop, while your S4 is your atrial gallop, no? Your S3 is caused by a few diseases, namely among which is our ischemic heart disease, okay? And your anemia, okay? Anemia. S4 could be caused by a few diseases as well, namely among which is your coronary artery disease, and your hypertension. Okay? Now, mautana ka na ako, sir. Why is it that your S1 is best heard at the base? Okay? And why is it that the S2 is best heard at the apex? Base. No. Why is the S1 best heard at the apex? And why is the S2 best heard at the base? Simply put, di ba S1 class, no? It is the closure of your AV valves, atrioventricular valves. Now, if you look at that anatomy of the heart, no? The AV valves are much lower or much inferior compared to your semilunar valves. Okay? Which is why, and if you remember, the apex is the lower part of the heart, no? Whereas, no, the S2 is heard during the closure of the SL or semilunar valves. Anatomically speaking, the semilunar valves, no, they are superior compared to your atrioventricular valves. So they are much closer to the base. Okay? They are much closer to the base. Ayan. Next is we auscultate for murmurs. Okay? Auscultate for murmurs. Now, a murmur is a swishing sound caused by turbulent blood flow through the heart valves. Okay? Or great vessels. Use both the diaphragm and the bell to auscultate the precordium for murmurs. Now, ang tendency mga good class is a murmur, no? They have a variety of pitches. Meaning, some murmurs could be high-pitched while some murmurs could be low-pitched. Diba? Some murmurs could be high-pitched, some could be low. That's why it's best to use both. Diba? It is best to use both so that we can determine if there is actually a presence. No? Now, class, when we are assessing for murmurs, assess first while supine ang patient. After that, you repeat the same process again, but this time while they are left side lying or left lateral position. Okay? And then lastly, assess them while they are sitting, leaning for a while forward and exhaling. Okay? Naglingkod sila, they are sitting, lean forward and exhaling. Okay. Now, normally class, there should be no murmurs or negative murmurs, no presence of murmurs. Abnormal findings class is if na ay murmurs, obviously if there are murmurs. Okay? Now, here are some specifics, no? If we can find or if we can hear murmurs, okay, while they are left side lying. If we can detect murmurs while they are left side lying, it is indicative of narrowed blood vessels. Okay, narrowed blood vessels. Otherwise known as our stenosis, diba? Narrowing of blood vessels. However, if we can detect murmurs while they are in a sitting position, this is a sign that there is possible backflow of blood. Okay? Backflow of blood. Now, in the playlist, no, I will try to add a video that will let you hear murmurs. Ang tendency mong good is most of the videos about murmurs, they are very what they call this, very complicated, so to speak, because pang medicine mong guna siya, no? Backflow of blood is otherwise known as your regurgitation. Okay? Regurgitation of blood. Okay. Now, another thing you have to take note when it comes to positive murmurs is you have to document it. Okay? You have to document it. Now, there are specifics to documentation which we will discuss now. Okay? This is the general guidelines for documenting murmurs. Okay, now don't mind the chart first. Okay, let us start with the guidelines first. Okay, now, when documenting murmurs, when you are documenting, okay, you have to take note of 5 things. First is the position patient was in when murmur was heard. Okay? So, for example, the patient was heard during a left side lying. Diba? Ano ba? Something like that, no? Next is area of precordium where it was heard. Okay? Next is the intensity and pitch. When we say intensity, it is volume, no? It is either loud or soft, banging, booming, and when we say pitch, either high or low. Okay? Number 4 class is if there is variance. Okay? When we say variance class, what we mean by that is if it is radiating. Okay? Radiating to another area, or if it is not audible in another position. Okay? And lastly, class, very important class, is the grading. Grading of murmurs. Okay, now let us discuss. Okay, let us discuss first. So muna siya, no, grading of murmurs. Grade number 1, guys, these are murmurs that are barely heard. Okay, grade 2, it is soft sound but easily heard. Grade 3, moderately loud. Grade 4, loud with a palpable thrill. Now remember, for grades 1 to 4, you will still need to auscultate. Okay? Grade number 5, very loud with a palpable thrill. And lastly, class, it is heard without a stethoscope. So here, no, if even if you do not auscultate, you can still hear the murmur. Okay, the whooshing sound. Okay, normally you can hear a grade 6 just by putting your ear at the chest of the patient, no, makadungog ka, grade 6, but you cannot hear it when it is still grade 5, no. So for example, class, when we are gonna document it, it's like this. Okay, let's say for example we heard the patient when they were supine. Okay, the area of the precordium, let's say for example the fourth intercostal space, left mid clavicular line. Okay, intensity loud and what do we call this, high pitched. Okay, we need to be accurate about the pitch, magod, because these are accurate descriptors so that the physician can accurately diagnose what type of murmur that is. Okay, radiating to another area. Okay, the murmur moves to another side, nga na. Okay, let's say for example not applicable atong variance. Okay, it is not applicable. And let's say for example the grading is grade 4. Grade 4, that is how you document a murmur. Okay, murmur heard while the patient was supine at the fourth intercostal space at the left mid-clavicular line. It was loud and high-pitched with no variance, graded at grade 4. Ayan, something like that. That is how you grade your murmurs. Okay, now mag-breaks ako before we will proceed.